answers. So David, I think you're going to take us through some of the questions that have come out.
Yes, indeed. Lots of questions, mainly around regulation and inspections. The first one says, where an organisation is providing services across the board, primary, urgent and community services, is primary care still going to be inspected separately, or will an organisation be inspected as a whole?
This is a really, really good question. And if I start, and then my colleagues might want to come in on this, because as we know, as you probably know, our legislation has allowed us to regulate providers that are registered with us, legal entities that are registered with us. Now, increasingly, we know that health and care isn't delivered in quite such a black and white way, and there's increasingly new models of care where we've got primary care networks with lots of different organisations providing care. We know with the changes that we're making with our new strategy, we are going to be addressing some of this by looking at multidisciplinary teams in an area who understand those complex models of care and can work to regulate in a much more joined up way. And we've been testing this with the urgent and emergency care that Andy was talking about earlier, where we've actually been scheduling inspections and looking at how teams are working right across the urgent and emergency care pathway. We'll also be looking at the integrated care system through the system lens at how all of the different providers are working to deliver care. Where we haven't got to yet, but something I think we do need to consider going forward, is actually things like primary care networks, which are not legal entities with us, but increasingly maybe delivering services across multiple different organisations, how we regulate those effectively, because I think that's something that we are increasingly seeing. We don't want to add on extra layers of regulation by layering on different levels in which we regulate, but we do need to make sure that particularly where those arrangements are not within one organisation, that there is clear governance arrangements, that there's clear accountability, and that people working in those arrangements are supported and supervised properly. For example, if you've got a pharmacist that's working for several practices in a primary care network, how do we make sure that that pharmacist has got the appropriate support and supervision and understands where to go to for help? So lots that we're working through in that area. I don't know if Tim, Andy or John, you want to add anything? Tim?
Yeah, thanks, Rosie. I think it's really quite exciting the way that we're actually changing our approach, because as Rosie says, it gives us this ability to think more holistically about the way that care is given. And I think it is a great question, because where we're seeing, for example, hospital trusts taking over the ownership and the governance of groups of practices local to their trust, it will give us an opportunity to reflect on the most appropriate way, depending on exactly what the question is that we want to ask. So as Rosie has quite rightly said, it's going to be an iterative approach. We're learning as we go as well, in all honesty, but it's a real opportunity to hone our regulatory processes and get it right and focus on the things that are really important to people.
Thanks, Tim. Anyone else want to add anything, or should we go on to the next question?
It might just be worth throwing in there that there's an increasing amount of corporacy in health and social care services, and I think, again, as Tim has said, that corporate development often will be multidisciplinary, and I think it's important that we do work in getting that regulation right so we don't duplicate unnecessarily.
Thank you, John. Completely agree. OK, David, shall we go on to the next question?
Yes, a short one. Has the single assessment process been piloted? If so, for how long, and will the results be published?
Good question, and the short answer to that is not yet. So this is very much in the plans. We are at the fairly early stages with this single assessment framework in terms of working through the detail. We absolutely want to pilot this, and we want to learn and iterate it so we make sure that it is as effective as possible. So we will be looking at providers to work with to make sure that we pilot, we learn, and we won't be rolling anything out until it's fully been tested.
Thank you. And just some clarification here. Are the Chloes being replaced by the 5 key questions and quality statements? And if so, when will Chloes stop being applied?
So the assessment framework, when we roll it out, that will be where we change the terminology from the into the key questions and the I statements and we statements. So John or Tim, do you want to add, or Andy, do you want to add anything to that? No. Blank faces. So I think no, absolutely. I think it's essentially when we roll out the new assessment framework, we will be changing the terminology from key lines of inquiry to the I and we statements and the quality statements that we'll be looking for.
I think it's still worth putting, though, in the context here, is that the things that make good care good and less good care less good are not really going to change, whatever the badge is, whether it be a key line of inquiry or whether it be an evidence category, as we've been talking through there. Those things remain the same. It's just that we're looking at changing the way we do it to make it more appropriate across all areas of care and not separated out as we outlined earlier.
Yeah, very good point. And this, the reason we're putting this single assessment framework in is because in the past we've been told we're inconsistent in terms of how we look at the different sectors, and we very much want to address that. We do listen to what people feedback, and we have listened to a lot of feedback which is informing the way we do things now. So good question. David, do you want to give us the next question?
Yeah, a question around data. It will be most helpful and transparent if CQC can share the list of resources you collect the data about practices from. This will help us prepare better for inspections and in turn provide better care. Is that something that CQC is able to do?
Yeah, so I'll start and others might want to join. We want to be as open and transparent as possible with everything we do. We're not here to trip people up. We want to drive improvements in care with everything we do. And if people can have access to the data and be working on that data long before we arrive or look at it, then that's even better because patient care will improve as a result. So absolutely, we will be as transparent with the data we're looking at. In fact, Tim, you might want to just come in here and talk about the clinical search work and what we're doing.
I was very keen to do so, Rosie. Yeah, I'm a real fan of transparent regulation. I think it helps people to understand what we're looking at, especially when there's a shared view of quality with the profession. As many of you, or if not all of you, will be aware, for over a year now, we've consistently uploaded sets of clinical searches as part of our inspection, again in response to concerns that we were hearing that there was a lack of consistency and a consistent approach, and that we weren't always looking at things that were important to clinicians and to patients, and that's why we've changed this focus. It has taken a while, but we are just about, and watch this space, it's in today's bulletin, I think, Rosie, trailing it around about a month's time, probably very early May. We will be explaining how every practice can actually upload the version of searches that we will be using on inspection, and that's a marker of how transparent we actually want this to be. I think in relation to where we go, using searches is really quite a labour-intensive way of looking at clinical records, and what we're trying to do is to develop sort of passive data feeds, really, and we're also committed as much as we possibly can be to not duplicating requests for data. So we were hoping that NHS Digital's programme would have come to fruition. It looks as though that's not happening as quick as we thought it might do. So we're now actively exploring exactly what we will be looking at. But absolutely, I'm a great fan of making that transparent as soon as we know what we're doing and what we're collecting, because that in itself drives quality and is a lever for improvement.
Thank you, Tim. And just to be clear, the clinical searches we were talking about there relate to the general practice sector, and the kind of clinical searches we can undertake in general practice systems. John, do you want to say anything about data in oral health?
Well, I mean, the main thing about data in oral health is that there's a bit of a split between private providers and NHS providers. With NHS dental services, there's quite a lot of data that's produced by the NHS Business Services Authority, and that separates out into things that they call the dental assurance framework, which is very helpful to know whether the services that dentists are providing within the NHS are effective or not. In terms of private dental practice, there's very little data, and I think we need to have further discussions with dentists across all spheres of practice to see actually how we can either obtain data that will help us understand how effective practices are and whether the level of care that they're giving is good or not. So I think we've got more work to do on that front.
Thank you, John. And I think, Tim, you wanted to come back in?
Yeah, I really agree with John about, and it translates into independent primary medical services as well. We're working with organisations to try and develop a consistent approach to data collection and an ability for independent primary medical services to be able to benchmark their data, for example, but not exclusively related to developing a questionnaire which really quite mirrors the GP National Survey.
Thank you both. David, do you want to come in again?
Yes, there's a few comments and questions around the pandemic. I'll read one of them now, and it says, regulation is important, but also should be made simple and open so we can concentrate on our main work. We are still recovering from the pandemic and in a national recruitment crisis. The morale has never been so low. How are you taking this into consideration?
Yeah, so a really important point. We are fully aware of the massive challenges that all sectors are facing at the moment and have been for the last 2 years. We know it's been an incredibly difficult time, and those pressures are getting, if anything, getting worse rather than better, particularly with vacancies, recruitment, problems, and the whole range of issues causing increased demand. I go out and visit providers on a regular basis and hear that firsthand, and we work very, very closely with all of our stakeholders and partners across the sectors so that we really fully understand that. Our job as a regulator is to ensure that people get safe and high quality care, and it wouldn't do anyone any favours if we said that everything was okay at the moment. Really, it wouldn't help the sectors in terms of making sure their messages were heard about the problems that they are experiencing, and it certainly wouldn't help people using services, many of whom are struggling to get the care they need. We do know that there are providers that, despite all of those challenges, continue to deliver good quality care and safe care. We know that that is challenging to do, but I think part of our role is actually how we share that best practice, how we share the learning, but also how we escalate to our national stakeholders, particularly government and ministers, which we do regularly, the pressures that people are under and what people are experiencing. So we are taking, we are listening, we are aware of the problems. We're trying to undertake our work in as compassionate way as possible and as supportive way as possible. But ultimately, our role is to make sure that people do get safe care, and we will continue to do that. So it's a good question, and I just want to take this opportunity to say a huge thank you to everyone working across all of the sectors and all of the services you work in. And I know it's been a difficult time. I know that people are working immensely hard at the moment. The other thing I just would add before I stop is that actually where I'd like us to get to is that we could go in any day of the week into any provider, and what we look for is business as usual. And in the good practices that we go into, in the outstanding practices, they don't have a kind of mad scramble for 2 weeks before we arrive. What we look at is stuff that means care is safe, processes are safe, systems are safe, and those are the types of things that providers should be looking at on a regular basis, whether or not we're coming in to see them. And I guess the other side of the coin that we see is that we hear from a lot of whistleblowers, and that's been an increasing problem over the last couple of years. And the whistleblowers we hear about are the people who are working in areas where they feel that safety is not being considered. And that has a huge impact on recruitment and retention, and particularly in terms of retention of staff. We know that there's a massive link between health and well-being of people who work in services and patient outcomes. They're very linked, and we know from quite often the whistleblowers will talk to us about bullying, harassment, where they're not being supervised, where they're not getting the support they need. And so we do take all of that into account when we're looking at our regulation as well, because I think ultimately, if people are feeling that they're able to deliver safe care, then you're much more likely to hold on to those teams and hold on to those people working in services. So there is a definite link that we have to think about with that as well. So I don't know if any of my colleagues. So Tim, do you want to come in first?
Just to add, I agree with all of that, Rosie. And I just wanted to add that we are acutely aware that one of the effects of the pandemic is that not as much is in the direct control of providers. If we look at secondary care waiting, for example, and the impact that that has had on general practice services. We've seen the evidence from the King's Fund that's been published over the last few days that patients are actually feeling the pressure as well in relation to wide services, including GP services. It's just to say that we've started a piece of work to help us to more consistently describe, especially where there is good and outstanding care, but also where care is actually being delivered in a suboptimal way, so that we're more consistent in actually describing the causality of why that is. And I think that's going to be a helpful piece of work and helpful for practices to understand why a rating might not be good, and where their part in that rating is.
Okay, thank you, Tim. So I think we've got time for one more question, David, if that's okay. So
yes, and the most liked question today reads, why don't CQC produce a single guide for primary care that lists all the things that will be inspected? That way practices can prepare properly and will improve care as well. Is that something we are able to put together?
So I'm guessing, David, when someone said primary care, they actually mean one of the sectors within primary care, because obviously there are differences between dentistry and general practice and pharmacy and optometry. We don't look at pharmacy and optometry, but I'm guessing that the question means that they'd like a single guide as to what CQC looks like in dentistry or general practice. Am I right in thinking that? But John, do you want to come in first and then Tim?
Okay, well, thanks for passing that hot potato over. Actually, I think one of the things that's really important about primary care practice, I think whether it's GPs, whether it's dentistry, is that we're professionals, and actually we understand from our own knowledge and for our own learning how to deliver safe and effective care in the particular environment that is personal to us. Just from having looked at the early gestation of this assessment framework and the evidence that's going to be required, I think that most providers, when they have a look at all of that, it'll be reasonably simple to work out what CQC is looking for. But actually, I wouldn't want to deprive people of the ability to develop that for themselves in the way that suits their own practice environment and the patients whom they serve.
Great, thank you, Tim.
Yeah, just very briefly, Rosie. I think there is a risk to being really explicit and reductionist in a list of what CQC is looking at, because by definition there'll be stuff that's not on the list that remains important, and the clinical searches are a great example of that. They're exemplars of what good clinical care looks like. They're not meant to be exhaustive or a replacement to a practice's own clinical governance. Thanks.
Thank you very much. And we know that everyone's working in different contexts with different population groups and different areas. So I agree with your comments there. Lovely. Well, I think we've come to the end of our time, very sadly, and we could have had a lot more time answering your questions. But please do continue to keep in touch with us. Feedback through the channels we've talked about. We will be looking at all of the questions and comments from today, and we will be addressing these as we go forward, and so do have a look at our bulletin and all of the information we send out as well. So just a huge thank you for joining today. We will be continuing and thinking of further sessions like this to continue to update you as we go forward, and really appreciate your time.